Let me introduce properly Dr. Paula Gordon. Thank you so much for being with us today. And I will tell you a little bit about how I met her. But Dr. Paula Gordon is a clinical professor of radiology at the University of British Columbia and was a founding medical director of the Sadie Diamond Breast Program at BC Women's Hospital. She was named one of Canada's 100 most powerful women by the Women's Executive Network in the Trailblazing and Trendsetter Award category. She is one of the greatest Canadian specialists in detection and diagnosis by the Ministry for the Status of Women. And she received the Prix d'Excellence Award from the Royal College UBC Radiology and Research Discovery Innovation Award, as well as, drum roll please, appointed as an officer in the Order of Canada for her work and what she has done in the area of breast health. And this is not a woman that you should listen to and call it a day. This is a woman you should listen to and start getting on your soapboxes like me and Angel were earlier, right? And how I met this woman is because I suffer from dense breasts. There you go. There's one for the podcast. So I know we're not on the podcast, but and I met Dr. Paula Gordon in an appointment. And she was telling me things as we were lying there and and she was testing things out and doing what she was doing. And she was telling me things. And as she was telling me things, I was in shock. Because when you think you know, and you think that you know enough, I do this and I get this and I have a relationship with my doctor. And she was telling me things and my mouth was getting bigger and bigger and bigger. And it was really shocking in a soapbox kind of way. I was like, please come onto the show, please share. And I know that she does that often because it's what you don't know that sometimes can get us in trouble. And I got to say, as the more years that I get on the planet, I have such a higher, I always believed in education and passing that on, but just such a high regard for the power of even a little bit of information, even a little bit of information. Okay, so Paula, thank you for coming and joining our Stand Up, Speak Up, and Show Up Summit. You certainly do that.
Thank you.
Absolutely. So now I know that we've got some slides and I know that we've had great conversation. We were chatting the other day and would you like to bring up the slides first? Would you like to have a bit of a conversation first? Do you want to do them together? What do you think's best?
Well, you gave me a bit of a segue by saying that you suffer from dense breasts. And I hate to start out with a contradiction.
No,
but
go for it.
I need to contradict you on that. Now, I'm not sure where all the participants that are on are from, but in British Columbia, women know a little bit more about dense breasts than in other provinces because we were the first in Canada where women were told their breast density and whether they had dense breasts on their routine screening mammography reports. But I want to make it very, very clear that it's normal and common to have dense breasts, and it's not something you suffer from. I'll go into a little bit more detail, but about 43% of women over the age of 40 have dense breasts, and most don't know it. And that's because the only way that you can know if you have dense breasts is from a mammogram. So if women haven't had their very first mammogram, they won't know, no matter what. And depending on where they had their mammogram and what kind of mammogram it was, they may not know either, because in screening programs, women are typically told their breast density. At least it's on the report. There's now 6 provinces in Canada that tell women their breast density on their screening mammography report. But if, let's say, the only time a woman's had a mammogram is that she had some symptoms like a lump and she went for a diagnostic mammogram, it should be in the report, but it's not necessarily communicated to the patient. The family doctor probably wouldn't have said anything to the woman. So it is normal. About 43% of women over the age of 40 have it. And what does it really mean? Well, all women have different kinds of tissues in their breasts. Lots fat, ordinary fat, and then the glandular tissue, where the milk is made when a woman's nursing, and then the supporting structure. So if you can combine those two, you'd call them the fibroglandular tissue. Let's just call it the normal breast tissue and the fat. but what's normal for one woman isn't always normal for the next. So one woman might have 100% fatty breasts, and another woman might have 100% full of dense tissue breasts. Now, the best way to just show you this, I don't know if Dorothea has made me a co-host so I can share my slides, but I would like to do that. And that, because I mean, a picture's worth 1,000 words here.
Yeah. Right.
So let's see what we got here, if this is coming up the right way.
Fabulous. Yeah.
Screen sharing, but I didn't need to share all that. Yeah. All right. Well, I'm not going to spend a lot of time fixing it, but let's do this. Stop sharing. Go back to the slide and show it like. Here we go. Now, here, can you see it now? Can you see it yet?
No, we actually saw it and then it pulled back. So
okay, hang on. I'm going to show it. I hope this is it. Here we go. We didn't do that. We didn't prepare for this part in advance. Okay, so these are the 4 different categories of breast density. They're all normal, and look how different they look. This breast would be almost entirely fat, and the dark gray stuff is what normal fat looks like. The white stuff, these are blood vessels and what we call Cooper's ligaments. Category B, which is also not dense, you can see there's a little more white stuff, and that's what normal breast tissue looks like. And this is category B, which we say has scattered densities. The next 2, category C and D, are the dense breasts. This one has a little bit more white, but not totally white, and that's called heterogeneously dense. And this is extremely dense. There's hardly any fat in this breast, and it's all normal tissue. The reason this is significant is you can see normal breast tissue is white, but when a woman has a cancer and even other non-cancerous lumps are white on a mammogram. So if a woman has a cancer, a white cancer, and she's got this kind of breast tissue, it's going to jump out at us. It's going to be really easy to see. I say it's like seeing a star in a dark, starry night. It'll be a little harder to see in this breast. It'll be considerably harder in this breast, and it can be virtually impossible to see a cancer if you have category D breasts. So that's one consequence of having dense breasts that women need to know. You need to know if you've got category D, there's a 50% chance that even if you have a cancer, we won't see it. Now, let's go back and look at the next kind of issue, which is, okay, so you just told me that I can't see all cancers, and the likelihood of missing a cancer increases as women's breast tissue increases in density. So let's look at, here's a video I'll show you, I hope. And if you watch a tiny little cancer up here, there it is. You can see it in her. You can see it there. Oops, but you would miss it if it was there. You can see how much harder it is to see that cancer, and harder yet in category D. So the denser a woman's breast, the higher the possibility that that if she has a cancer, that we won't see it. So that's one reason women need to know if they have dense breasts, because it means you can't totally trust your mammogram. You should have mammograms, absolutely. In fact, we know that it's best for women to have a mammogram every year, regardless of their density. But the other reason women need to know if they have dense breasts is because women with dense breasts are at a higher risk to get breast cancer than women with non-dense breasts. So we call that the double whammy. You're at an increased risk to get breast cancer, and we're less likely to be able to see it, but still go for the mammogram. And if you are mammogram age, which means 40 plus, and if you've had a mammogram, if the information isn't in your report, ask your doctor, insist on knowing your breast density. Now, we have a bit of a knowledge gap for family doctors, and this is a big deal, and this is a much bigger story. But there's a panel in Canada that makes guidelines for breast cancer screening, and it's called the Canadian Task Force on Preventive Healthcare. And that panel is described as being expert, but they are not. There are no breast cancer experts on the panel that made the guidelines. And one of those guidelines is that women with dense breasts don't need any special attention. Well, from what I just told you, that's obviously wrong. But because family doctors don't realize that the panel are not experts, they tend to trust what they're told by that panel. And so if that panel's guidelines are no big deal for dense breasts, you're going to have trouble getting that information from your family doctor. And even if they do give you the information, they may not be willing to go the next step, which I will tell you. There are other tests that can be done that will find cancers that are missed on mammograms. And the easiest and cheapest test is ultrasound, which is widely available everywhere. In Canada, there are places that refuse to use ultrasound just to do that extra screening for women with dense breasts. But then again, you've got to advocate for yourself. And this is where the stand up and speak up. Yes, you speak up. Advocate with your family doctor. And, you know, that can be pretty intimidating. There's so many people who don't have a family doctor. Women are afraid to speak up because they're worried that their family doctor is going to drop them. And if you need help with the conversation, there's scripts that you can use with your family doctor. And I'm going to give you two websites. One of them is densebreastscanada.ca. And the other is mybreastscreening.ca. Full disclosure, I am a volunteer advisor to those websites. And the Dense Breast Canada is an organization formed by women who've had breast cancer that was delayed in diagnosis because nobody told them they had dense breasts. They didn't know the consequences of having dense breasts, and they were in no position to advocate for themselves. It's really important that we get screened. And as I told you, the primary method for screening is mammography. And the reason that we screen is twofold. One is to find cancer earlier. And when we find cancer earlier, we're more likely to be able to treat it without harsh therapy. And women are more likely to survive their cancer. So we want to find cancer as early as possible, often many years before the cancer would become big enough to feel or even see on a mammogram. We also want women to be able to be treated without having the most aggressive therapy. If a woman has an early breast cancer, she can have a lumpectomy, a small operation, rather than a mastectomy, which is when the breast needs to be removed. Part of breast cancer staging, when a woman first has her diagnosis or surgery, is to sample the lymph nodes in the armpit. And there's an operation called a sentinel node biopsy, which is much less aggressive and has fewer complications. One of the complications of the sentinel node biopsy is a swollen hand and arm, which is permanent. It's called lymphedema. Many of you may have actually seen a woman wearing a lymphedema sleeve. It's like a compression sleeve. They now make them in patterns and colors, almost like looks like a tattoo on the woman's arm, but really it's a fabric elastic sleeve. If women have the sentinel node biopsy, the complication of lymphedema is much less. So that is a great reason to want to find cancer earlier. And finally, nowadays, if a woman has a cancer detected earlier, she can even skip chemotherapy. So these are the reasons that we want to screen for cancer. And it's important because the stage of diagnosis, when a woman's diagnosed with cancer, the stage impacts her survival. If cancers are found at stage 0 or 1, the 5-year survival is almost 100%. But for women who are diagnosed at stage 4, it's as low as 23%. Now, in provinces where women can't have screening until they're 50, there's a much higher risk for women in their 40s of being diagnosed with stage 2, 3, and 4 cancer, even into their 50s. Because, of course, if you screen in the 40s, you find those cancers before they're found in the woman's 50s. So these are the reasons it's really important to know if you have dense breasts. And there are other tests, I won't give you the whole lecture, that can find cancers early. Most of you will know that one of them is MRI, but there's a lot of new tests being developed. So if I can leave you with, make sure you find out your breast density and then advocate for yourself, talk to your doctor, try to get sent a requisition to have a screening breast ultrasound. Now, the other point is when do you start screening? And we know that annual screening starting at 40 saves the most lives. And people sometimes ask me, well, why 40? You know, should it be any earlier than that? Well, it turns out that 40 is the sweet spot. And I'm going to show you this slide. Sorry, I have to keep going back and forth with this slide sharing.
Oh, that's fine.
Okay. Okay, it's the sweet spot. Now, breast cancer can occur, unfortunately, even in the 20s, but it's very uncommon. You've heard that 1 in 8 women will get breast cancer. Well, that only applies if we all live to age 90. The likelihood of getting breast cancer in the 20s is only 1 in 1,700. In the 30s, it's a little more, 1 in 230, let's call it. But look at the big jump between the 30s and the 40s. So this is where the incidence of breast cancer ticks up. It's not common, but it happens often enough that it's worth screening all women starting at age 40. And there's loads of research to show that it's completely safe. The radiation risk is virtually nil at age 40. It's actually pretty nil in the 30s too. Really, the radiation risk of a mammogram is only for somebody under 20, but we want to be on the safe side. So routine screening of all women should start at 40. And I'm talking about average risk women here. If women have other risk factors, like a family history, it might be worth starting earlier. But here's how the incidence keeps going up. And unless a woman dies of something else, her risk of breast cancer keeps climbing. So women should keep having mammograms as long as they're in good health with the life expectancy of about 10 years. Now, I talked about average risk, and these are the risk factors for breast cancer. I'm not going to discuss all the ones you can't control because you can't control them. I want you to know, though, there are ways to reduce your risk of getting breast cancer. And here's some of the factors that you can control. Combined hormone therapy taken for menopausal symptoms. If taken for longer than about 5 to 7 years, there is an increased risk of breast cancer. So if you're on hormones for menopausal symptoms, you got to talk to your doctor periodically and see if you're ready to try weaning off. Dietary fat is a risk factor. All of these are actually just really things that increase our general health, not just breast health. You don't want to have a very high fat diet. We now know that alcohol is a risk for breast cancer, and there's no safe level, but the new Canadian guidelines are try to keep your drinks to 2 or less a week. I have women say to me all the time, oh, I don't have to worry about alcohol. I only have a glass of wine with dinner every night. That's too much. Really, make alcohol a treat, not a regular thing. We know that women who don't exercise are at a higher risk. So yes, get out there and do your 30 minutes minimum 5 days a week. Stop smoking if you're smoking, and then get to and stay at a healthy body weight. These are the factors for breast cancer that you can control. Now, some women say to me, well, I don't have to go for mammograms. There's nobody in my family with a family history. Big surprise. And even a lot of doctors don't know this. 85% of breast cancers occur in women with no family history. And that's why all women need to be screened, not just women who are at increased risk. Now, if you do have a family history and in a first-degree relative, which would be a mother, sister, or daughter, a woman's breast cancer risk nearly doubles. But remember, 85% of breast cancers in women with no family history. In other words, said the other way, less than 15% of women who get breast cancer have a family history. Now, in addition to a lump, because lots of people think that's the only way they're ever going to know if they have a breast cancer, I do encourage breast self-examination. But breast cancer can show up many different ways. And this is a really cool website, knowyourlemons.org. They have an app you can download, and just using lemons to show all the different ways that breast cancer can show up. It can show up as a lump, but it can also show up as some skin that's pulled in, a sunken nipple or sunken skin somewhere else on the breast, or when the skin gets thick, like an orange peel. Sometimes it's discharge from the nipple. Now, having said that, most discharge is not cancer. Do not squeeze. The only kind of discharge we worry about is the discharge that comes out all by itself without squeezing. And even then, if it's white, yellow, or green, believe it or not, that's okay. It's the bloody discharge or completely clear. So have a look at that website because there are many more ways that breast cancer can show up. Deb, did I cover? I mean, I should leave room for questions, and I haven't been looking at the chat, so fire away.
No. That's okay. That's okay. Well, I think that's a lot to digest. And one of the things that I would say is, and we talked about this earlier, sometimes this is a difficult topic. People don't want to talk about it. People don't sit down with their kids and talk about it. I know I certainly didn't get it as part of my, when I was in school, it wasn't talked about in PE or health, or when my mom told me about menstruation, she certainly didn't tell me about breast health. And even for myself, my daughter's 30, I didn't know enough to tell my daughter about breast health. And so I think there is this kind of, I hope it doesn't happen to me and it's over there kind of thing, right?
Well, this ties into your speak up and stand up. I always whine that the women who are doing all the work in advocacy are the women who've already had breast cancer, and all the outcome of their hard volunteer work is not going to benefit them because they've had cancer. They're no longer at average risk, because once you have a cancer, you're at an increased risk to get either a recurrence or even a new cancer. We need more women who haven't had breast cancer yet to help us with advocacy. And that means talking to politicians, talking to their elected representatives, be it at the provincial or federal level, because of course, both have an impact on our health. We need more non-survivors. I call them previvors. They don't know yet that they're going to get cancer, but we need help. I just noticed somebody had a question about thermography. Thermography has been completely discredited as a screening test. It can find big cancers that are close to the skin. It measures temperature differences. And we have no trouble finding the big cancers close to the skin. Either they show up on a mammogram, or the woman can usually feel them, even if she's not doing breast self-exam, she's washing herself and she can't avoid touching it. But in terms of screening, they have far too many false alarms, and they miss cancers. They miss, cancers that are deeper in the breast. And so unless you're a -A cup like me, it's hard to feel all the way back in the breast. And that's where mammograms come in. But I'm glad somebody asked that question, because they're not covered by health insurance. Both the FDA and Health Canada, you can look up thermograms. They both say they should not be used for screening. And so somebody's written, come to the US to get a mammogram before 50. Well, there are 4 provinces in Canada that allow women to self-refer. If you want to know if your province, I'm not even going to tell you which they are, because I want you to go look at mybreastscreening.ca, and there you will find what's available in your province. But even if your province doesn't start their screening program till age 50, the Canadian Task Force that did not recommend screening starting at 40 did say that if a woman wants to be screened, it's her decision and she should be able to. So if you're in one of those provinces, don't go to the US. They're really they're overcharged. But go to your family doctor and have one of those conversations, the scripts that I told you about, to advocate for yourself and get a requisition. And you can have it in Canada. You might have to have that conversation more than once, because a lot of family doctors are wrong, and they say, oh, you don't need it until you're 50. But there are far too many stories of women who asked for a requisition and were turned down. And then within a couple of years later, even before they turned 50, they were diagnosed with cancer, sometimes at an advanced stage. It's tragic. So stand up for yourself.
And we were also talking, I'm glad someone brought up geography, because we were also talking about this. I mean, this is a global, international, and obviously you're going to have to go to where you are. But I was quite surprised when you were talking about the advocacy that's needed in Ireland, for example. So what in Europe, please share what's going on there.
Well, okay, there's another website that I also consult for. It's an American one. It's www.densebreastinfo.org. And they have a European site, and it's mainly an American organization. The Americans were 10 years ahead of us advocating for dense breast notification and supplemental screening, but it varies by country. And if you have participants in Europe, they can go to that website, densebreast-info.org, click on the European link, and then every single European country is listed, and you can find out when the screening starts and whether they have dense breast notification and so on. There are two countries, France and Austria, where if a woman has dense breasts on her screening mammogram, she's automatically called back for ultrasound, and they do it as part of their screening program. In BC, where I am, which was the first province to tell women density, and women can now have screening covered by our provincial health insurance, it's still not done through our screening program. You have to get a requisition and find some place that will do it. But so it varies all over Europe, just like it does in Canada. In the US, I said, they started 10 years ahead of us. They've got as far as 38 states and the District of Columbia have some sort of legislation that women should be notified and so on. But the FDA has now ruled that all women in the US should be told their breast density. They should be told the consequences of having dense breasts that I've just told you. And they should be told that there are supplemental tests that can find cancers that are missed on mammograms. Those supplemental tests, only because somebody mentioned thermography, they're generally based on a woman's underlying risk. So an average risk woman would probably go for ultrasound. If a woman has the BRCA gene, then she should have MRI every year in addition to her mammogram. And then the intermediate risk women, there are some other tests, contrast enhanced mammography, which is it's getting off the ground. It's a great test, especially for women who can't tolerate breast MRI or can't have it because they've got a metal pacemaker or something in them that makes them not a candidate for MRI. And there are other tests as well, but those are the main ones. Sorry, I got way off topic. Did I answer your question?
No. This is exactly on topic. Angel, I can see
totally.
it. Yeah.
Totally on topic. And, I'm just thinking this is our 5th summit together. It's the first time we're talking about our breasts, right? And having a physician here to talk about women's health. And so Deb, thank you so much for having dense breasts. Can I say that? Right? For getting Paula on her soapbox to bringing us here and making this, just getting this message out and making this so valuable. And so Paula, right? I think that for all of us, like it should be in our short to-do list, right? And if we're going to set our goals, is to go out and make that appointment to get our mammogram, and to take action, right? And to speak up for ourselves. But beyond this, like what do you see like as the future, like the changes? Is it early detection? Is it, do we see this? Like
it's everything. It's everything. And the people who are not supportive of aggressive screening, and aggressive, I'm meaning optimal. I don't say it's too aggressive. They use the excuse that, we don't have to do so much screening now because the treatments are so much better. But the treatments work better in early detected cancer. And there's even research to show that, because of course, nowadays, if a woman isn't having screening and she gets breast cancer, so maybe it's not as early, she's going to get state-of-the-art treatment, whether her cancer was found at screening or not. But there's been some fabulous research done in Sweden that showed that a woman's outcome, she's 60% less likely to die of breast cancer in the first 10 years after diagnosis if she had screening. She's 47% less likely to die of breast cancer in the first 20 years after her diagnosis if she's had screening. Yes, I know women who are diagnosed, I told you, 23% 5-year survival for stage 4, but there are loads of people alive thanks to all these fabulous new therapies. But one of the other reasons that people don't support screening is they say it's not cost effective. Well, you know what? These new treatments are super expensive. And what happens is a woman has an advanced cancer, she's treated and she does okay. And then her cancer comes back and then she goes up the next notch in treatment. And so we now have data. It's actually been submitted for publication. I'm sorry, I can't tell you the numbers, but in the old days, somebody with stage 4 cancer, it was relatively inexpensive to treat them because they died. Now they can live for years and years and years, and the treatment is extremely expensive per case, which makes a much better, if you want to never mind the saving lives bit, it makes a much better case for cost effectiveness because it's so expensive to treat advanced cancer.
Paula, let's talk a little bit about, because some women are afraid to go get, like, they don't know what they don't know what it feels like. They could have heard like, oh, it really hurts to get a mammogram, or I'm not comfortable taking my shirt off in front of somebody, or like, really, what is a mammogram? What does it look like?
I'm going to show you. And,
right.
and I'm glad you asked that one. So first of all, mammograms are uncomfortable. If they're not uncomfortable, they're not good quality. But here's basically what goes on during a mammogram. The breast is compressed between, this is the compression plate, this is the image detector, what's actually making the picture, in two positions, the top to bottom squish picture and this angled picture, which is roughly parallel to the pectoral muscle. It's not straight up and down because we all have breast tissue going up towards the armpit. And this shows much more tissue than if you did a top to bottom. And it should be uncomfortable, but not excruciating. And I mean, I just had my mammogram last week. I can tell you, it's like, oh God, yeah, I forgot how uncomfortable it is. It's sometimes more uncomfortable if you're smaller because they're squishing my pectoral muscle. There's not a lot of breast tissue to squish, but it's brief. It's a few seconds. They get you in position. And I always sort of giggle, except you can't giggle, because the technologist will say, stop breathing. And I'm thinking, you're kidding me. You think I can actually breathe? But it is uncomfortable for a few seconds. And then as soon as you hear the beep that the picture was taken, it releases the compression. It used to be that you'd hear the beep and the tech would walk around and unscrew the compression device. Now it's automatic on every mammography machine. They are uncomfortable. I'm not going to tell you they're not. But the reason we compress is to spread the tissue out, which makes it easier to see cancer, and it reduces the radiation we need because the breast is thinner. So it's critical. There are some tests like ultrasound where we're compressing the tissue just by pushing the probe while the patient's lying down. Of course, they're more comfortable, but mammograms are the gold standard. They can find cancers that ultrasound can't. There's some data to show that if you're having MRI, maybe you can get away without the mammogram, but MRI is really not well tolerated either. You lie down on a table, the breast coil looks like a box with 2 holes in it. The breasts are hanging down into these holes, and then you're pushed into the tube. Women who have any claustrophobia don't tolerate it well. And even on Twitter this week, there was a conversation with actually a breast cancer survivor who's a physician. And she said, I hated that MRI. It made me cry. And she was asking, is there any alternative test? Well, contrast enhanced mammography is going to be the replacement for MRI for people who absolutely can't tolerate it. But you need an intravenous injection. You need one for MRI. You need one for contrast mammography. And for contrast mammography, you need the squish too. So there's no perfect, comfortable, easy peasy test. But that's the price of early detection. The MRI also uses a contrast called gadolinium. The contrast they use for contrast enhanced mammography is the same one we use for CT scans, CAT scans.
Wow. Now I know, and if there's any questions, please put them in the chat. We had a good conversation this week, and we were talking about, okay, so what can we do? I mean, there's a place where you can send us and people can donate, because like you said, it's usually survivors that band together, because once you find out this information. But what can we do? I mean, one of the things I just thought about is like, oh my gosh, I haven't even told my daughter, like what, how, you just don't think.
Okay, so but for a 30-year-old, what you really want them to do, if they don't have any increased risk, like a first-degree relative with breast cancer, you want them to start paying attention and do breast self-exam. Now, that term has gone out of favor. The Canadian Task Force said women shouldn't do it. The Canadian Task Force said even doctors and nurse practitioners shouldn't do a breast exam as part of a routine physical. I don't even have a problem with that if women are examining themselves, because you just saw how different a breast can look on a mammogram and still be normal. Same thing with a breast exam. Some women's breasts feel soft and uniform. Other women's breasts feel like a bag of marbles. Some women's breasts just feel like solid concrete. Each woman's normal is unique to her. And a busy family doctor who sees 25 women a day, even if they make a note in the chart, can't remember from one year to the next exactly what you felt like last time. Whereas if you're the only one that you are examining, you're going to kind of get the idea without even making a diagram or taking notes. You're going to know that, oh yeah, that feels about the same as usual. And it is so impressive to me when a woman comes in and says, I felt something different. And she's right. And it turns out to be a cancer. It can be the most subtle thing that if I was doing a breast exam on her, I might go right by. So women should be aware. They should do, and they don't have to do it. They used to say you needed to do it every month after your period. You don't have to do it every month. It doesn't have to be obsessive, but pay attention, get to know what your normal feels like. And in order to remember what it feels like, you got to do it periodically. I won't say every month. Always do it when you're just finishing your period, if you're still having periods, because most women's breasts get more lumpy and tender feeling before their period, and then that regresses after their period stops. And take a look in the mirror. I mean, if you see, oh, what's that indentation? I've never noticed that before. And, there's the old instructions that they used to give out for breast exam. They said, here, hang this in your shower. It'll remind you. They said, press your hands together, or lift your arms over your head, see if there's any puckers or anything underneath. It doesn't have to be that thorough. Just pay attention. And age 30, that's what women should be doing because they've established their periods. You don't want to do it when you're a teenager. And then 40, mammogram, ideally annually, but no province in Canada. I think maybe Yukon lets women go annually, but most don't. Now, for example, in British Columbia, women can self-refer starting at 40, but they can only go every year if they have a mother, sister, or daughter with breast cancer. In Ontario, they can't start till 50 unless they go to their doctor and advocate for themselves and get a requisition. But one good thing Ontario does is women can self-refer annually starting at 50. So every province is different. That's why that mybreastscreening.ca website is helpful. You'll at least find out what's going on in your province. And if people are inclined to donate, absolutely. Dense Breast Canada has a donation button on their website, and you'll get a tax receipt. I think the minimum is $20 to get a tax receipt. But these are the people who are doing all the work, and it is entirely volunteer run. There's no paid staff. And for example, the last outlay that I know about, like, for example, they make brochures, that I can give out if I'm speaking at a meeting. But the last outlay that I'm aware of is for a lawyer's letter, because we're actually challenging the University of Toronto, who were the home institution of the Canadian National Breast Screening Studies, which we now know are corrupt. We want them withdrawn from the literature. Though that study done in Canada, but it was poorly designed and poorly executed. That's the main reason our task force says not to screen starting at 40. So we never spend money that we don't have to spend. We've got pro bono help every chance we can. But there are expenses, and right now it's just coming out of the volunteers' pockets. So there is a campaign to raise more money so that we can do more of this advocacy.
Absolutely. And wherever you are, whatever country you're in, I am sure there's organizations that need that support. Can we talk about the word anxiety?
Yeah, absolutely. Because the task force says there are 2 reasons why women shouldn't have mammograms in the 40s. one of them, the one they care about the most, is that they say that when women are recalled after a screening mammogram for more tests, it makes them anxious.
Hmm.
Well, yeah, of course it makes them anxious. But then they find out that everything's fine and that anxiety goes away. There's research showing that there's no long-term harm from that transient anxiety. On the other hand, if you don't screen women starting at 40, you're going to miss the opportunity to find those lethal cancers that they're going to be diagnosed with sooner or later. I mean, it doesn't mean they're not going to get cancer. So women find this horrifically condescending and patronizing, that this panel would rather more women die because they claim to be sparing women from some of that transient anxiety.
Mm.
Isn't that powerful information? Like, isn't that powerful information? And thank you for being so transparent, because here's what I think sometimes. Because people have had maybe a difficult time getting information from medical doctors or medical practitioners or surgeons or what have you. Sometimes there's been a bit of a shuffle, and we all know that systems are taxed even more so now than before the last couple of years. And we still have, I remember Lloyd Robinson on CTV News, he did an interview with me, and I was talking about, he found out that I had an aromatherapy company. He's like, what's one of the biggest challenges? And I'm like, we are scared. We're scared to ask for a second opinion. And so there's this barrier, I think, that's been created that's not necessarily true, of the medical system all wanting to keep its information to itself. So I think the barrier that I hope, one of the barriers that you broke today, is that there is doctors willing to share and, speak and not be quiet and not keep things to themselves and not misjudge our ability to take that information in a very intelligent manner, right? So I appreciate your advocacy today.
Well, let me just say, I mean, this is my passion, is education right now, educating women and physicians. A number of the lectures that I've given were recorded, and many of them are posted on Dense Breast Canada. I've done some 1 minute, she calls them reels. I think that for Instagram, I don't know. But whole lectures, these 1 minute reels, the information is out there. And if somebody writes to the executive director of Dense Breast Canada, it's info@densebreastcanada.ca, and has a particular question, she'll forward it to me and I'll answer it by email. Now, obviously, I can't give individual medical advice, but in general, that's, and talk about biases and full disclosure, I don't read screening mammograms anymore. So I'm not doing this so that I'll earn money because more people go for screening mammograms. That's something that when you're giving a talk to an academic audience, you have to say what your disclosures are at the very beginning.
Angel?
Oh my gosh, this is so good. I'm so glad we're talking about it. This has just been so empowering, right? As women, like, to give us the language, to give us the verbiage that we can go in and be advocates for ourselves, and just to have you just kind of leading that charge for us is like, hallelujah. Thank you so much. Right? This is incredible.